So good afternoon, everybody. Welcome to the August session of the Center for Global Emergency Care Speaker Series. Today we have the pleasure of welcoming back a graduate of Hopkins Emergency Medicine, Dr. Bachar Hamade. And he has been very busy since leaving Hopkins. He did a 2-year crit care fellowship at Pittsburgh and then moved to back to Lebanon as a clinical instructor in both emergency medicine and surgical critical care. Uh, and came back to us back to the US anyway, in October of 2020, relocating to Cleveland Clinic, where he works as both an emergency doc and surgical intensivist. So, Bachar, it's a real pleasure to welcome you back to the Hopkins community for this chat, anyhow. And thank you so much for making the time. I can only imagine how busy you are. We can get started whenever you're ready.
Sure. Thank you so much, Bhakti and Nico, for the great introduction. It's really cool to kind of see a lot of familiar faces and to kind of be virtually back on the old stomping grounds. I'm going to say, I'm just going to talk to you guys about my experience back in Lebanon. Let me see if I can share my screen, and if that works, and we can get started. So can you see? Does that look okay?
Yes.
Yes, and now you're in presenter mode.
All right, perfect. Okay, well, so good afternoon. Thank you again for inviting me to talk to you about my experience in the Beirut Blast. Like Nico said, I'm Bachar Hamade. I'm staff at the Cleveland Clinic. I split my time between the emergency department and the surgical ICU. This is pertaining to my experience back in August in Lebanon, where I spent a year basically at the American University Beirut Medical Center, working as both an emergency physician and a intensivist between July of 2019 and October of 2020. I think the Beirut Blast made it kind of on the global news headlines for quite a while back in August of last year. And the way I'm gonna kind of construct the talk is we'll talk a little bit about the port blast itself, about the disaster activation process at the hospital, the response, the successes and the challenges, and then basically coping with the next day after that. And I'd like to take a step back and talk about October of 2017. And I think pretty much everyone would recognize kind of that incident, which was the worst mass shooting in US history in Las Vegas. And actually, EP Monthly at the time ran a story with Kevin Menace, who was the head emergency physician at the time at Sunrise Hospital and Medical Center in Las Vegas. And this small kind of emergency department was able to handle, I think over 100 of GSW victims in one night. And I remember reading this and I was at awe as to like how this was able to happen and what was going on through his mind and the team's mind, and how they were able to function under such circumstances and implement, a disaster plan that I think was uncomparable up until like maybe this day, and we don't really see that very often. And we'll come back to this in the end, but I just kind of wanted to talk about that early on. And I'll give a brief kind of intro with this slide about, Lebanon in terms of its unfortunate violence timeline. As beautiful as a country is, it is no stranger to violence. And it has experienced, since probably February 14 of 2005, when Prime Minister Hariri was assassinated. And this picture is, the crater that it created when his motorcade blew up. And since the last 15 years, between 2005 and 2020, there have been several armed clashes of militias, more than a dozen car bombs, targeted assassinations, and actually more than 65 conflict-related mass casualty incidents, always kind of on the 20, 30, a little bit less in the teens numbers, but has accumulated 100 of people unfortunately losing their lives and being temporarily or permanently wounded. However, I think really nothing compares to August 4 of 2020, which was the Beirut port blast. I think this was labeled as the probably biggest non-nuclear explosion that has pretty much rocked the world. And it happened around 6:07 p.m., August 4, 2020, where around 3,000 tons of ammonium nitrate that were improperly stored in the Beirut port in one of the kind of reservoirs in one of the storage areas detonated after a fire had broken out and lit up in the vicinity. The explosion was felt around 160 kilometers away. So actually Cyprus, which is a neighboring country in the Mediterranean, was able to actually feel the shock wave. It left around 6,500 people injured, 220 dead during that day. Around 300,000 people were displaced from their homes. Resulted in $4.6 billion worth of damage. 120 schools were destroyed. 6 hospitals suffered significant damage that are still undergoing repair, and 22 healthcare facilities were also damaged. This is a shot of the port from one of the buildings in proximity that basically looked like almost like a skeleton after the impact. On the left is a short clip of the time of the explosion. It basically looks like a nuclear explosion with a little bit of a red mushroom cloud and then just shockwaves traveling through. And on the right is my ex-living room, basically where I used to rent an apartment with my wife in Beirut, which is around 3 miles maybe away from the explosion. And that was our living room that kind of blew in with glass shards everywhere. And I fortunately was sitting on that couch actually, and my wife had called me into the kitchen to ask me for something, and then the explosion happened. So I think we both were very fortunate to make it out of there safely. But this just to give you an idea about the extent of the damage, several miles away. This is an aerial footage, kind of a satellite photo of the Beirut harbor and the port. And you can see on the left, this is what it looked like before the explosion. That's where they stored all of the kind of wheat silos and just a lot of storage containers for trade. And on the right, you can see the effect of the explosion and the crater that it created kind of into the sea, and then pretty much destroyed everything in the vicinity of it. Truly, it looks like something out of a movie. Here are just a few more pictures about, just kind of wounded civilians and the extent of the damage and car destructions and buildings. And just wanted to share those to kind of get things into a little bit of perspective. So because of the unfortunate violence that Lebanon and Beirut has endured over the course of the last several years, and over the last 15 years, the emergency department at the American University of Beirut Medical Center, where I used to work, was able to really implement a great and well thought out and implemented disaster plan, where they noticed over the course of the years that you always have around like 15 minutes. When something happens and you have to activate disaster and get everything in motion and get everything set up, you have around 15 minutes where you have some time to prepare. And I think these are like the golden 15 minutes. And that's where you can activate your disaster protocol and get everybody that you need to come in. You can implement security and force crowd control around the hospital. You can set up triage, get patient registration to come help you, set up all of your pre-printed and MCI kind of wristbands. It's easy for us then to kind of go into and start tracking patients once we go into disaster mode and have all of our pre-identified, little MCI wristbands, and then go into surge capacity and bring out all of the medications that you need, all of the supplies that you need, get all of the consultants that you need, and then obviously facilitate communication between the different services in the hospital, between the different leaderships in the hospital, and between the hospital, the ED, and the family members outside waiting to hear any news about their loved ones. This was a little bit different, and I'll play this because I think it was a little bit more personal. It was a little bit more internal, and this kind of happened in-house, I would say, despite it being around 3 miles away. the effects of the explosion kind of hit right into the emergency department. And I hope this plays out. It's only a couple of seconds, but it gives you an idea about the entrance of the emergency department. And people had initially kind of heard about what's going on. They walked outside and they felt a little bit of the rumble, and then kind of the world exploded, I would say. So I'm going to play this for a second. Oh, I'm sorry, I went back here. And I think, you know, this really clearly delineates basically how traumatic this experience is, in the sense that the ER itself suffered damage, and you know, our staff and the nurses had to kind of realize what happened before they sprung into action. And that's where you lose your golden 15 minutes, especially when things happen right at your doorstep or in your hospital. So the emergency preparedness plan at AUBMC was really kind of, like I said, implemented over the last few years, around the last 10 years, developed in really solid fashion and extensively developed. And its activation is based on geographical location. So the map on the top actually shows a map of Beirut with the suburbs around Beirut. And as you can see, there's this yellow box, and the port is around here where the red circle is. This yellow box is, this is the blow up of it. And anything in the vicinity of where the hospital is, which is around here, anything that happens, any mass casualty incident happens around the hospital in this geographical area, warrants an activation, a disaster activation in our ER. And there are several levels. It starts with mass casualty alert, where it's just kind of an alert and everybody's kind of on standby until they hear different news. And then there's a partial response, which brings, you know, kind of the very kind of important stakeholders to the table, the ED, physicians, you know, trauma surgeons, et cetera. And then there's a full disaster and mass casualty kind of code deactivation, where everybody shows up. And there are different lists for every level. Everyone will get a page. Everyone will get a WhatsApp kind of application text message. Everybody will get an SMS text message. And for some reason in Lebanon, data worked better than SMS. And so WhatsApp was kind of the modality that was used mostly. And I bring this up because based on the geographical location, we shouldn't have activated our disaster response. But as you can see from the extent of the damage and how strong this explosion was, we had to, because we felt it. We thought it was at our doorstep. And then all of the neighboring hospitals around the port suffered extensive damage that they couldn't keep up or take care of the patients, and they lost most of the facilities during that day. So what happens when the disaster alert is called out? There's a downstream chain of effects where reinforcements are called in. And that's your ED staff, you know, residents, standby, you know, medical students who are rotating in the ED. Everybody, med 3s and 4s that are in the hospital will come down to the ED. All of the trauma surgeons, surgical residents, consultants. And then you get, you know, your orthopedic, neurosurgery. Everybody comes in and sees how they can help in this kind of situation. So all the supply carts are pre-stocked, especially also the medication carts, and they're all brought out from kind of storage in the ED, and they're set up in designated areas in the emergency department that are easy to reach and easy to ask somebody to hand you something in case you need it. The whole hospital goes on lockdown except one entrance, which is the ambulance ED entrance. Epic, which is the electronic medical record that we use over there, and I remember we used it at Hopkins as well, goes into disaster mode. And so you don't take any demographic information from the patients. There are kind of printed or kind of registered mass casualty identifiers that print out wristbands. Every patient gets, you know, a wristband. They have a new unique MRN. It follows them through their stay during that night, and then eventually via getting more demographic information down the line, links it to their old chart. Patient clearance happens along with surge expansion. Basically, everybody that can be discharged from the ED gets discharged immediately, goes home. You open up different areas in the hospitals, in the ICU. You move some patients out to the floor. from the floor to the hallways in case you need them. You open up the PACU, all of the ORs that are scheduled for the next day get canceled, for the same day get canceled, that are non-emergent, and then all of the ORs are open and ready to be used. And then expanding into the surge capacity areas, which is basically linked to patient clearance as well. So we'll talk about each one of those and what it means in terms of our disaster response. So when we talk about reinforcements, it means we bring all of the ED staff. So everybody at home shows up. Everybody who's, and this was a little bit problematic because a lot of our staff lived outside of Beirut. And so coming into the city sometimes is a little bit rough because the highway is clogged with cars and it's rush hour and traffic, etc. But everybody gets called in. Every nurse that's available gets called in. All of our pharmacists get called in to help with medication and dispensing, and they actually kind of run around in the ED trying to see who needs what in terms of RSI medication, antibiotics, sedatives, etc. All the respiratory therapists, minus a few that stay up in the ICU to manage the ventilators up there, or also those guys would come down and help. Radiology, which is key in these situations, comes in. So the radiology residents, they all come in, all the staff comes in so they can read in real time, x-rays and CTs and give immediate results. Obviously the trauma team is there and all the surgical specialties and consultants that you need, like ophthalmology, ENT, neurosurgery, etc. So that's all the reinforcements. And in this particular case, literally everyone showed up. The supply carts and medications, like I said, are pre-stocked and they'll come out and they'll be put immediately into certain areas of the ED that are very easily reached. And they include, they're basically kind of crash carts that have all the equipment that you need. They include all of the RSI medications, all your fluids and crystalloids, ET tubes, lines, chest tubes, everything that you might need in a resuscitation is there and readily available for you. I think this is a very important aspect of the disaster response, which is lockdown and crowd control. This is the front entrance and the ambulance entrance for the emergency department. And this would be the only entrance that's available for anybody to kind of walk into the hospital from. And as you can see, it's a metal door. And I think the department learned the hard way that, glass can only prevent maybe a few people from coming in, but not a stampede. They'll break the door down and kind of run into the department. And the reason is, emotions are extremely high. Everyone's anxious. They want to know what's going on with their loved ones. And they're not going to take no for an answer. So unless you implement security, lockdown, and crowd control, if the mob outside runs into your ED, then it's game over immediately. And you get swamped and you have no idea how to manage your emergency department again. So this was very important. Epic goes into disaster mode. So no demographic information, just kind of random MRNs, random names, all kind of pre-registered and identified, switches into disaster mode. MRNs follow the patients all throughout the night until we're able to link them to their old charts back. And then patient clearance and surge areas. So the ED immediately gets cleared out. Everyone goes home, who can go home, tell them to come back tomorrow. The floors, patients are moved out of their beds if they're very stable into hallways to make room for new patients that need a little bit more attention and management. The ICU was a 12-bed med-surg unit in addition to a 10-bed neurosurgery unit. And we kind of shared beds amongst all of us in terms of the specialties. And all of those patients that are stable can get moved into the floors if they don't need vents or if they need BiPAPs, so we'll be able to do that. In addition to the ORs, like I said, getting kind of equipped and open for everybody. And the PACU holds around 17 patients easy, so that turns into an ICU as well. And one of the intensivists can go and mainly handle it down there and take care of the patients down there. This is a schematic representation of the emergency department, and it's kind of like the blueprint picture. And I'll go through it pretty quickly here. So this is the ambulance entrance, and that's kind of the metal door that we were talking about. And once you walk in, this is the main emergency department that is highlighted in red. And this is the high acuity emergency department. Here in a circle is the resuscitation bay and the trauma bays. This has around 4 to 5 beds that can fit in here. Walking down this way, this is usually a lobby for like a waiting room or just kind of a lobby for family members. However, this turns immediately into a green area and is set up as such. The part of the emergency department that's here in the back is the low acuity or pediatric as well, mixed low acuity and pediatric emergency department. So that stays as it is, but splits into a yellow and a green zone. And then on the second floor, we have another low acuity emergency department and space that gets flipped into a green zone as well. And obviously there's several rooms here, but if you have enough stretchers, you can just kind of put people in the hallway and take care of them. So all in all, the way it was set up is that triage, it's a 40-bed ED, and that's how much it fits bed-wise. In terms of areas, the triage area was set up at the metal door at the ambulance space. So that's where the patients roll in, that's where the ambos come in. And usually you want an experienced physician to be there at the door and who can direct, where the patients are going to go and triage them. However, our nursing staff and is extremely experienced with mass casualty incidents and disasters. And so most of the times, actually, we have one of our senior RNs out at the door doing triage. ED1, which is the high acuity area plus the trauma bays, that's around 19 beds, and that's usually staffed with the ED physicians, also the residents and the surgical teams. The ED2, which is the low acuity delineated in yellow that I showed earlier, is around 7 beds. Those are bed spaces, I would say, staffed with ED physicians. And then 3 and 4, which is kind of where the pediatric side was in the back, where the lobby is, and upstairs. Those are around like 14 beds in total, not accounting for the lobby in which you can kind of use that for, and are staffed by intern PGY2 surgical residents and internal medicine residents. And the backside of the ED1, kind of in the corner, that is the black area for the deceased. So I'll talk a little bit about my personal timeline about kind of when this all unfolded and my personal experience during that night. So after the explosion, it obviously took a little bit of time, which seems like an eternity, but was only probably like 5 minutes to kind of understand what had happened, and not really kind of know exactly what had happened. All I knew was that something blew up. My house is now blown into, which was a big traumatic incident, obviously, and so had to make sure that my neighbors were fine, and then I immediately kind of got all my stuff and then ran to the ED, which was only literally a maybe 2-minute walk from where I used to live. I lived very close to the hospital. And so when I came outside of the emergency department, I can only describe this as, just kind of sheer and utter chaos. This picture right here is towards the end of the night. So by that time, the crowds have kind of, shrunk a little bit in size, but it was just mayhem as soon as I got there. And initially, I was kind of at a loss in terms of, should I kind of just run into the hospital in the ED? But there's a lot of stuff going on out here. And so I opted to start helping, patients and help family members get, the injured out of cars. There's people kind of on the street. There was pretty much blood everywhere. There was glass everywhere. All the glass in the surrounding buildings had shattered and just kind of spilled over from, top floors, like 10, 12 floors up. And so I saw one of the surgeons outside, one of the more kind of senior surgeons, and we just started basically, getting patients out of the cars, putting them on stretchers, putting C-collars on, doing a quick assessment, and moving them over to triage. So that's where I started for around like 20 minutes until we were able to actually set a little bit of a system going on outside, and then I went in. And when I went into the ED, I found immediately looked for my the incident commander, basically, and who was in charge of the situation, which was my ED chairperson at the time. And so I immediately went to her and I was like, where do you need me to be? And she was like, well, I don't have anybody on triage yet until somebody comes in like senior, like we have one of kind of the junior nurses, et cetera, maybe man that for a little bit. And then I'll see where you need to go. And so we immediately go from an ESI system to a START system. And this is just a brief kind of figure to show what I'm talking about. Patient comes in walking. If they're walking, then we just put them in green. They get secondary triage, and infants obviously are first, et cetera, et cetera. If they're not walking, do they obey commands? Yes. And they have a palpable pulse? Yes. Then they go to the yellow zone. If no, they go to the red zone. And I think the hardest part is if they're coming in and they're not obeying commands, they're not walking, they're not obeying commands, they are breathing with an open airway, you send them over to the red side, they're not breathing with an open airway. Eventually, most of the times it leads to the black zone. So that's what I did for around 45 minutes. Between 6:07, I think I got to the ED around maybe 30 to 35 minutes later. By that time, it was crazy. I did 30 minutes of triage. And then once I had more senior residents and I had a more senior nurse at triage, I broke off and I went into the resuscitation bay and the trauma bay. And that's where I spent pretty much the next few hours of my night, which to me, I think at the time it was few hours. To me, it felt maybe like 30 minutes because I think I was functioning at some form like a machine. Like I don't know how to really explain it. And I think to this day, I don't think I'm ever going to kind of duplicate what happened that night between me and the rest of the staff that was there. And it was me and another emergency physician, one of my colleagues. We were running the trauma bay ourselves. And so we had, 4 stretchers, but we were able to fit up to 6 and 7. And we just kind of implemented, a very, very clean protocol of, patient comes in, they don't have a pulse, CPR is happening in the field with EMS, et cetera, then we just don't do anything. We just call. It goes into the black zone. And I think this was the hardest because culturally in Lebanon, nobody gets called in the field. Everybody gets, a CPR run. It's a cultural issue. It's more for the families, et cetera. And obviously we don't really talk about it during disasters in terms of how EMS should handle it because family members are usually with the patient. And so this thing continues to happen until they end up in our ED. And during this particular scenario, it was just straight to black. If they do have a pulse, then immediately an ABC. And if the airway is compromised on any level, we didn't think twice about it, we just intubated. Because we had no time to think and observe and, the airway is okay for now, maybe we'll reassess later. It was RSI, intubate, and then go. Pretty much everybody got IVs. If you couldn't get an IV, they all got groin lines or subclavians. And then if there was any form of crepitus or, asymmetrical chest or the chest x-ray showed us a pneumothorax, we didn't even think, we can observe the small pneumothorax, they got a chest tube. And then right after that, immediately imaging would happen. So quick portable chest x-ray. And then the resident who was helping us would accompany that patient onto the CT scanner, spend time with the patient there until they got their CT scans. Radiologist reads the CT immediately and gives a rundown of the injury complex. And from there on, the resident communicates with the surgeons and they make a decision, either goes to the operating room or goes to the ICU upstairs or to the PACU to kind of board pre-OR or if there was no more space in the ICUs or the PACUs, they come up back to the ED and we just kind of board them there until they're able to go back to the operating room or to the ICU. So on that day, we saw around 360 patients that we can tell, but I think we saw a little bit more than 400, especially with the patients that showed up in the first wave and eventually got discharged immediately and were told to come back the next day, were never registered. We admitted around 87 patients, 19 to critical care beds, 16 ORs that night, and then 52 to the regular floors. And we discharged around 261 patients on the 4th of August. So that was kind of what we estimated what we saw. And this was also very important because the first wave of patients that shows up is usually not the ones that need a lot of work. They're the ones that overwhelm your department, but they're not your sickest ones because they're the ones that are immediately right outside the door where all the glass fell on them and now they're covered in blood and now they run into your ER to get help. So you get overwhelmed by that group of patients, but they're not your sickest. And that's why you need to continue to set up and implement, a good triage system, and to know where you need to put your staff, because after an hour, once, the search and rescue starts and they're pulling people out of the rubble, those are your sick ones. And that's why I kind of personally went from, outside of the ED into triage, and then eventually relocated into the Resus Bay. And unfortunately, we lost 12 patients that day, either that came in dead or came in alive and then lost the pulse during resuscitation. I'll start talking about challenges and successes now. And I think the biggest one, despite everything else, I think that one of the biggest challenges is recognition and comprehension. I think I think to this day, all of us that kind of went through that experience still think about it. Sometimes I'll just randomly talk to my wife about it, and especially since August 4th of 2021 was just a couple of weeks ago. And it was just a sad day, because we just looked at did we really go through this? And this was a year later, and we still are replaying things back in our mind that what happened that day. And I think it was even harder on the staff that was working that day, because they were taking care of patients and immediately the roof was falling on them, and they had to get up, take care of themselves, take care of the patients that they were treating, and then look up and see a wave of people rolling in. So, and you didn't have much time. They had maybe a few seconds to understand that this was real, this was reality, and this was not like a dream, and this needed to happen. So I think this was a big challenge. One of the successes was activation. In an explosion such as this one, the lines immediately go down. You can't call anyone, you can't talk to anyone. And so it was very hard for the staff that was in the department, and they felt extremely kind of vulnerable that they couldn't call for help because the phones immediately were not working. And the mobiles kind of jammed. So data wasn't working, SMS wasn't working, the paging system wasn't working. And so one of the staff had to run upstairs to the communication center and the operation, the operator room, and tell them that we have no phones that are working. Please radio this out or figure out how you can get it, how you can get the signal out. And fortunately, 20 minutes later, the jamming kind of got relieved and everybody got the text messages. But there was a period of 20 minutes where it's kind of like they were sitting ducks and just kind of helpless on their own and trying to deal with this situation. Just two physicians and a couple of residents and a little bit of the staff. Obviously, then everybody from the hospital came down, but it took a while for it to get activated. And despite this problem, there was only maybe a 20-minute delay. A huge success was expanding into the surge areas. Like I said, it's a 40-bed ED. We had 87 admissions that night, and we were able to see around 400 patients. And this happened really kind of streamlined, and everybody knew that they were doing. And the chairperson of our ED was in constant communication with the ICU staff and with the OR staff, with anesthesia, surgery, et cetera, to be able to, and hospital administration and leadership, to be able to figure out how to accommodate all of these people. Because after a couple of hours, we kind of hit a gridlock, and we were like, well, what do we do with all of these patients? And so that's when we opened up the outpatient departments that were closed off, and we put some medical students up there with some residents to do suturing and some minor kind of care. The ICUs were completely emptied, spilled into the respiratory care unit, which is where we usually take care of our COPD patients and chronic lung disease patients. And the PACU was definitely mobilized and used as an ICU for pre-op or further stabilization. So this happened in a very well kind of thought out fashion, and just kind of was extremely streamlined, and I think was a huge success to accommodate such a heavy number of patients. Crowd control, I'll go back to this for a second because I think this was a great job done immediately with all forms of prior experience. the whole kind of hospital went on lockdown. The metal doors came out, and these are like sliding metal doors that go from side to side, so not front to back. They immediately were rolled in, and maybe 30 minutes later, a lot of Army personnel showed up to kind of, keep everybody calm, make sure no fights broke out. Because, like I said, an angry crowd rolls into your ED. It's just game over. There's no way you can function, and fights are going to break out, and then they're gonna try to see if the patient you're taking care of is their loved one or not, and then it's just a mess. One of the biggest challenges that we faced actually was registration and patient tracking. And the reason is, like I said, we had pre-filled MCI identifiers with MRNs that we would print immediately wristbands and give them to patients. And with all of the previous history and all of the other MCIs and disasters, we've always anticipated that we need maybe 180, 190 max, because most of the times they come in the teens, the 20s, 30s, and so you had time to print those out, you had time to kind of track patients, etc. And so this was immediately, we immediately ran out. We ran out of numbers, and at the same time, unfortunately, there were a few layoffs that happened like a week earlier, so we had completely new staff that was dealing with registration, and so they had no idea what they were doing. And so we just didn't know who the patients were, and we had no idea how to track throughout their stay. And so what eventually we decided to do was, whenever we had a patient, we try to get any information about age, for example, and then that patient, once they get like resuscitated, stabilized, go to imaging, we tag a medical student along with that patient, or like one medical student to two patients. And once they get the injury complex, they write it down on a piece of paper and they tape it to the bed. So eventually, when we did our tertiary kind of survey, secondary and tertiary survey on the ED, we would walk around and we'd look, okay, so this patient has 1, 2, 3, 4, and then we'd go through the injuries and then we'd re-examine, et cetera. And that's how we kept track of them. So this was one of our biggest problems. It was really turned into a really archaic system that night, but it still worked. Identifying the victims and communicating, like I said, we didn't know who the patients were. We had no names. It was very hard to figure out who they were. And so the family members outside were extremely upset, and rightfully so, and were frantic and emotional and trying to figure out if their loved ones were in the ED. And so at one point, our director went out of the ED and just started getting names from family members, would go back in and try to see if we can locate their loved ones. So communication was a little bit of an issue here, and was a little bit of a challenge. We deviated from standards of care, not because we like to, because we had no choice. No imaging was done prior to laceration repairs. It was basically staple, and just go. You staple over glass. You leave tendon injuries unattended to. You basically just give a shot of antibiotics or a pill of antibiotics, a tetanus shot, and you tell patients, come back the next day. Please come back the next day. This is not definitive management. We can't deal with this right now, but you're okay for the next 24 hours. Come back in the morning and we'll take care of it then more extensively. And I think personally, as an emergency physician, as an intensivist, we always try to do our best to help our patients, and we always, want to save our patients, and we never stop and we keep going. And this was one of the instances where I personally struggled with, and I think a lot of the other physicians struggled with, because we had to call things sooner than we usually do. I found myself working on a young female for, quite a while. I think for around 5 to 10 minutes, and then she coded, and then I kept resuscitating her, and couldn't get her back, and then eventually I had to realize, I can't keep doing this. I have to move on to the next patient, because we're just getting waves and waves. At one point, I was walking outside of the resus bay trying to see if anybody needs help in the main side. One of the residents grabs me and tells me there's a young male who's coding in the PACU, who was, I think, waiting for an OR, and I had no idea kind of what was going on with him. Went down there, like intubated him, coded him, decompressed both chest, etc., and then had to just call like 3 minutes later. I was like, we can't keep doing this. And I think this was our biggest challenge as a group. And that's when you feel that you could have always done more, but you couldn't, because this was just an unrealistic situation. Equipment was a challenge. We ran out of RSI medication. I think we ran out of Hamade by the middle of the night. So we were just intubating with midazolam. So just high dose midazolam. I think we still had paralytics. We were down to one ventilator. We almost ran out of blood. I think we probably did at the end, and we had one ventilator by the end of the night. So that was good. We didn't run out of ventilators. We started coming up with ideas about how to hook up two patients to one ventilator, and you can imagine this was in the middle of COVID. It was truly something that we didn't want to do, and I'm glad that we did it. But equipment was a little bit of a challenge. Imaging was another big one. Like I said, we had no way of tracking the patients for the first couple of hours, and so we had to make sure that whenever a patient got an image done, that this was the right patient, this was the right image. We write it down, we put it on the bed, we tape it. The medical student has it kind of on their notebook. The resident relays that information to the surgeon, etc. Because you can't pull up images in the OR. So when you're doing a cranie, you can't be like, hey, pull up the CT scan of that patient. You're like, all right, you look at it at the radiology in the radiology suite, and then you just have to go and take care of it. And our neurosurgeon did, I think, like 4 to 5 surgeries that night alone with another neurosurgeon. The biggest that I don't think you realize the same night, I think it hits you kind of after you're done, is the moral injury of the situation. It takes you a long time to process what had happened. I think it's something that affected our residents for a very long time. I think it affected me for a long time. I think that night I went to bed only for a couple of hours because I had to go back in the next day to take care of all of the other patients that we told to come back. And I think it really hits you as an emergency physician and an intensivist when you lose a patient, any patient, because you develop an attachment to that patient. And I think here it was on just a mega scale that was completely uncomparable to anything else that I've experienced. And so that's the reason why we did a lot of debriefing sessions that week and the week after with our residents, with the staff, with our directors, to talk about our experience, their feelings, what they think went well, what was bothering them from an emotional standpoint, to talk about it, to know that they're not alone. We all are feeling this way, and I think that was extremely important for us as a group to take care of each other. The day after. And I'm almost at the end, and I always like to end with this epilogue. This was an article that was published in Academic Emergency Medicine in October of 2020, so a few months after the explosion. It was published by one of the PGY2 residents at the time, along with the associate program director, and it's called Airway Breathing Circulation and Emergency Medicine Residents' Experience of the Beirut Explosion. And I think it really describes the emotional burden that one feels after such an event, and why it's important to be able to understand that and comprehend that and talk about it. So 2 days later, as the dust settled on Beirut, I returned to work. I was anxious, fearful, and had barely slept. However, no one asked me if I was ready, so I did not question it. That day, during a resident debrief, we had to know, could we have done better? Our attendings assured us that given the circumstances, the ED responded well. Although we could only remember chaos, they showed us that we had been organized, had assigned roles and teams appropriately, and communicated effectively. Still, I could not help but wonder if it was enough. As each of my friends shared their feelings, I cried. I cried because I finally realized I was not alone. That night, wide awake, I wrote it all down. I urge everyone to read this. I think it's an extremely kind of important and emotional perspective of what had happened. And I hope obviously nobody ever goes through this, but I think it's a really great paper. And at the end, I want to thank obviously, all of my colleagues back home who still are back home under even more dire circumstances than what we had been through. on the top left are kind of the ED staff, minus a few people. On the top right are the residents, some who have graduated, who did, I think just a fantastic, I can't even explain how proud we were of them, because they really stepped their game up tremendously. On the bottom right is our chairperson at the AUBMC Emergency Department, Dr. Hitti, whose guidance and leadership that night was paramount for this to be as hard as it was a success, I would say, in terms of a response. And on the bottom left are my two ex-surgical intensivist colleagues and trauma surgeons who were just like father figures to me back home when I started in my new job as staff. And in the middle, as you might recall from my second slide, I was talking about how amazed I was at Kevin Menace kind of running this disaster in the Vegas shooting, and how it's really unimaginable what anyone could go through. And unfortunately, we found ourselves in the edition of EP Monthly a few months after that. It's kind of ironic how that happens. But I hope that our experience, which I wish on no one, serves as a little bit of a guide or something to help other departments and facilities, develop or further enhance their disaster planning. And I hope that this experience they can learn from us. And I want to thank you all for listening. And this is the end of my talk. So thank you again.
Thank you so much, Bachar. That was very powerful, sharing in a really incredible experience. We do have a few minutes here where we can ask questions and discuss. Please feel free to raise your hand if you have a question, and we'll be sure to get to you. If you want, you can also put items in the chat. And Bhakti, you are the first hand raiser, so go ahead, the floor is yours.
So, Bachar, thank you so much for going through that and with so much detail. So, it really strikes me how traumatic this experience was. And I think I would like to ask a follow-up question about that in a second, but a really practical question to start out with. Like, what struck me the most was how thorough your preparedness plan was, right? Like the fact that the carts get mobilized, we have these T-sheets, people get wristbands. Like, I've been in too many disasters at downtown and we have none of that stuff. Like, we're meant to, but we just don't. So can you tell me, hey, did you guys do drills beforehand? Like, it seems striking that there must have been some significant departmental knowledge to activate so quickly, and how frequent those drills were. And the second was, have you guys done an after action review of your disaster response, and what were the amendments you made to your disaster preparedness plan?
Yeah, great questions. I think to talk about the first, we would run a few, and I think that unfortunately, our disaster drills are always real life experiences. So just to give an idea, I started in July or August of 2019, and even before August of 2020, we had activated maybe 4 to 5 MCIs. So they usually eventually take place of a drill, because it's just real life experience and everybody shows up and you kind of do what you're doing. Obviously not on this magnitude. We never imagined that we'd be in this kind of scenario. And that's how, over the years, before I even joined, this disasters plan was sought out. And honestly, it stems from also the survival mode of, just living in Lebanon. You're always preparing for, a disaster. And it's as unfortunate as it is, you're preparing for no power, you're preparing for no medication. So you're always kind of 3 steps ahead of the game. And so you find yourself that you've implemented a disaster plan that is phenomenal. And kudos to all of the group that was there before I even showed up. And I kind of did with them real life experiences that I would consider were drills for me before I even got to August of 2020. In terms of the second part of the question, or the second question, we definitely, did debriefs and we talked about it and what could we have done better. And this is stems from the challenges that we face. And I think it's a little bit, it was kind of ironic. We were like, all right, well, I guess we thought we needed only 200 wristbands. I guess we need 500 the next time. And it's kind of a little bit sad to say that, but now then we thought about how can we improve our communication? How can we improve talking to the leadership? And throughout the years, it actually got better, because in the past, you needed the hospital director to activate disaster. Right? And so that delayed your disaster activation by 30 to 40 minutes, because you had to call the director, you had to figure out if they gave the okay, etc. Versus then the emergency department took control of it after all of the experiences over the last years. We're like, look, this is just like time wasted, and we can mobilize everybody in like 5 minutes instead of waiting for you to or getting the call out to you to mobilize. So these are the things. And after that, I think we realized that we needed maybe more supplies, more ventilators, etc. And kind of how to get our registration. I think that was the biggest thing in terms of getting registration and identifying the victims and tracking them. So I hope that answers your questions. But yeah.
Thank you. It looks like Julia has a question.
Sure.
Yes. Hi. I was wondering, first of all, hi, I'm Julia. I'm a med student from Germany. And I was wondering, as upsetting it is that there are these places where there are catastrophes this often. At the same time, there lies great value kind of in this knowledge and this experience concerning these kind of situations. And this is more of a question maybe towards the whole group. But I was wondering if countries or places where the catastrophes usually are lower scale or just not as frequent profit or really look at these hospitals or these regions where there are these very well planned out plans. I mean, of course, I know also that hospitals here do these drills, but they usually do them with actors, and I feel like then maybe the learning experience might be smaller or something. Yeah.
So I think kind of from our standpoint, I think we, back in Lebanon, I think after the disaster, we the group submitted a few reviews about the experience, and I'm happy to send a few to Nico at the end, and he can kind of disperse to the group about our experience and about our protocols, etc. But I agree with you. I think. And I think Adam would say, the IFEM that we're part of actually is a great kind of platform to kind of discuss different experiences from more underserved areas where like disasters happen more frequently, and hopefully can implement some protocols to be able to extrapolate to more places where they don't. So I hope that kind of answers your questions a little bit, Julia. I know it's always when you're expecting a disaster drill, it's easier than the real thing. And it's kind of like I was telling Dr. Ansori that our drills were always the real thing, which is unfortunate, but definitely gears us up in terms of the experience.
Thank you, Bachar, and of course your participation in this is part of that knowledge sharing. You bringing back this firsthand expertise to help us inform our practice here. Andres, looks like you have a question.
Sure, thank you, Nico, and thank you so much, Bachar, for your presentation and for sharing your first-hand experience. I just had a question on this happened in the midst of COVID. I wanted to know perhaps how the blast itself affected healthcare provision for COVID-19 and for other services at the emergency room. Perhaps how what contingencies perhaps would have been good to have when you have so much demand for health services for COVID-19 and then this kind of disaster comes.
Yeah, thank you. I think that like the COVID-19 was like the cherry on top in the sense that like you had so many people in one space and so many patients coming in. And I remember that, well, the AC also kind of went out because we lost power for quite a while. And so I remember by the end of the night, I was literally just like drenched in like sweat. Like I think I lost maybe like 5 pounds like that night. And I think we had enough supplies in terms of PPE to last us the night, and we were trying to preserve as much as possible. Granted, it was hard. I think the biggest concern for us is like, what were we going to do, you know, following the explosion, and what the ramifications were following the explosions. Are we going to get, you know, a wave of COVID patients a week after that, you know, from everyone who was out on the street helping each other, etc. Obviously no masks, no social distancing, none of that stuff. So to tell you that, you know, we had a contingency plan on how to mitigate COVID or prepare for it, I think it was quite hard because we were already running out on supplies in Lebanon because of just the economical crash and the recession that's been going on. So we just had to make do with what we had. We definitely tried to divide the hospital with COVID, non-COVID, hot and warm zones. We tried to do that, but and we tried to dispo and discharge patients as fast as possible from the hospital during that week to open up more beds in case COVID patients came in. And I think this is just me talking about, you know, the AUBMC. However, other hospitals were extremely damaged that, you know, their COVID wards were completely blown up. You know, our COVID ward had maybe 2 beds that were now out of commission. So we had to makeshift new COVID suboptimal beds. But I think despite that, we didn't see that huge of a surge afterwards. I think we were lucky. I think it was pure luck. And I think it was pure luck that we, as the physicians and the staff, didn't all get COVID. So I hope that answers a little bit of your question regarding that.
Yeah, thank you.
Yeah.
Bachar, can I ask one more question?
Absolutely.
It's more of a human question. So when disaster strikes and we have all the plans and stuff, I'm just curious, you know, as a healthcare worker on the front lines in that moment, what would have helped you in the moment for your own personal wellness? Like, you know, if this happens again, I probably won't remember the preparedness plan stuff, but I'll probably remember any tidbits that you might have that tell me, like, what should I, as a human being, be doing for the other human beings that are in the trenches?
Yeah.
Like water or like a pea brain, like what was it that would have like helped you in the moment be whole?
I think initially on a personal level, even before I showed up, I think just kind of knowing that my parents were okay and like the rest of my siblings were. And I think I couldn't get in touch with them. And it's kind of, I mean, I say it's funny, but it's kind of sad funny in the sense that I was actually on the phone with my brother who doesn't live in Lebanon. And so we were on the phone, like having a chat, and then the explosion happened. And so I can't even imagine what he thought was going through his head because I couldn't understand what was going on. I couldn't relate to him. So I think, you know, communicating to families and our families as, you know, the physicians who are working, I think is important because I personally did not know what had happened until 11 p.m. that night. So I showed up to work and I just started working. I just started taking care of patients. And I just started treating patients. And I didn't know if my parents were okay. I didn't know if, you know, my colleague, you know, she didn't know where her fiance was and all of that. And at the same time, we're just kind of being mobilized to take care of the other patients. But I wish, you know, there was a way for somebody to be like, you know, your parents are fine, like your fiance is fine, your kid's fine, etc. I think that's extremely important because in the back of your mind, you're working and you're doing your job, but you're still kind of worried about that. And it's just kind of there worrying. And until I knew that, you know, my fiance, like my wife at the time, we were married. And I made sure that she was okay, she was safe. And then I figured out that her parents were okay, my parents were okay. That kind of made me okay to make sure that all of my loved ones were fine. And I can say definitely that, you know, the number one thing that rolled through everyone's mind when we were there is like, is my family okay? Like, are my parents okay? Are my kids okay? Etc. Because you can imagine if you're at work and your kids are at home, you know, and you with like your wife or husband or spouse or whatever, and you're like what, I don't even know how to get to them, or who to send to get to them. And I think that's the number one top thing that made us okay. And thankfully, you know, we had no losses from the department or from the hospital. One of our emergency physicians was actually, I think he might have taken that picture, the second one from the building that overlooked the port. So him and his wife and his young, like 4-year-old, they made it out, obviously safely by a miracle of God, because I really think it was so easy for them to have been killed.
Thank you, Bachar, for that insight. Maybe that's something that can make it into future disaster plans somehow.
Yeah.
So we'll just take one last question. I see Raymond, you have your hand up, and then just to be respectful of time, we'll close after that. Go ahead, Raymond.
Great, thanks. Fantastic talk, Bachar.
Thank you.
Very similar to the things when we responded to the 9/11 disaster and to the Haiti disaster in 2010. And we've been working on the one currently in Haiti. The question I have were kind of was one about the supply line. And during the Haiti disaster in 2010, I sent most of my medical team home and converted to a supply line for hospitals still needing equipment and supplies. How in your hospital did you communicate the need? What did your senior leadership, was Jamal still the chief of surgery there? And how did they, how did you get that communication? So what you needed and how they were able to respond?
Yeah, absolutely. A fantastic question. So I think initially it was our chairperson, who's Dr. Hete, and we basically have walkie-talkies. And I think that was important because we didn't rely on the phones, because the phone lines would go down, or the mobiles, etc. And so there are walkie-talkies, you know, stored in certain places that everybody will go to. And I think that was the main form of communication between our ED director and Dr. Jamal, who was the chief of surgery, in terms of the ORs, in terms of the ICUs, etc. And he would come down frequently from the wards downstairs as well, and kind of have a face-to-face communication. And you know, it's a small hospital, so it's easy to do that. And in terms of supplies, I think we had a lot of medical students, you know, running up and down to, you know, to go to the blood bank or to go to, you know, pharmacy, etc. And that's how we were able to mobilize all of the resources, in addition to everything that was pre-stocked and the supplies that were available in the ED for any disaster that happened. But that was a major form of communication between the different departments and the different chairs. And it was a lot of, you know, tell that person that type of thing, and that's the injury for that patient, et cetera, et cetera. And in terms of supplies, it's mostly kind of like I said. So I hope that answers a little bit of your question.
All right. Well, thank you so much. Thank you, everybody, for attending. We have recorded this, and we'll be able to post it online. We'll send more information about that. If that's okay with you, Bachar, we can
Absolutely
talk if you have any concerns. It's just a really powerful discussion, and I think we have a lot to think about and to take home after this, hearing about what happened, and that's it. Bach, did you have any final closing thoughts? And then we will.
No, just thank you so much, and you know, everybody else, come back in a month's time, and we'll have another excellent speaker, and give us ideas for topics or suggestions. And Bachar, like, we're here on Mondays. If you ever want to join us, we're all more than invited.
Absolutely. Thank you so much for giving me the opportunity to share this, and it's really nice to see, you know, familiar faces, and I see you, Bhakti and Nico, and please give my best to everybody at the Big Hop. I really miss everyone. So please.
Yeah, I'm going to send Gabe and Linda the recording right now.
Okay.
Take care.
Give them my best. All right. Bye-bye. Thank you.
Bye.
Thank you, everybody.